Well friends, today we'll see thyroid. Thyroid forms an important part of surgical aspects of various diseases. Now we'll start with the different tests for function of the thyroid. So first we have got serum thyroid hormones. So firstly we see serum TSH, that is thyroid stimulating hormone. Serum TSH levels can be measured accurately down to very low serum concentrations with a immunochemiluminemetric assay. When the serum TSH level is in the normal range, measuring T3 and T4 is redundant. So you may be asked a question, what will you do if your TSH levels are normal? Do you consider testing him further for T3 and T4, or you just carry away with only TSH estimation? So it is, you can do away with other estimations if TSH is normal, because we have developed now very much sensitive methods which will measure TSH to very minuscule changes in its concentration. Next we have T3 and T4. These are thyroxine and triiodothyronine. These are transported in plasma bound to specific proteins. These are called TBG, thyroid binding globulins. Only a small fraction of the total, that is 0.03% of T4 and 0.3% of T3 is free and physiologically active. It is called as free T3 and free T4. Assays of total hormone for both are not done now because of the confounding effects of circulating protein concentration. These are influenced by the level of circulating estrogen and the nutritional states. So rather than doing the total assays, now we are preferring to do free T3 and T4 because the total hormonal concentration may be influenced by estrogen and nutrition state. So this is very important because they may ask you which of the following influences in the body's total T3 or T4 concentration. Thyroid status at initial assessment is measurement of serum TSH and assay of antithyroid antibodies. These are supplemented by free T3 T4 evaluation when TSH is abnormal. So when TSH is abnormal, you have to supplement it with free T3 and T4 assay. We have got a syndrome which is Refetov syndrome, which is seen in patients with end organ resistance to T4, in which T4 levels are increased but TSH levels are normal. Free T3, which has got a reference range of 3 to 9 picomoles per liter, is most useful in confirming diagnosis of early hyperthyroidism, in which levels of free T4 or free T3 rise before total T3 and T4. So you may be asked a question, which of the following estimation will give you idea of early hyperthyroidism? So it is free T3, not free T4. So free T3 is very much important to diagnose early hyperthyroidism. T3 is most important physiological hormone and is also produced in periphery by conversion from T4. So you know from physiology or from biochemistry the T4 formation. So T4 is degraded to T3 and T3 is quick acting, which will act within few hours, whereas T4 will act more slowly, that is 4 to 14 days. So which of the following hormones is acting quickly? So you may be given action T3, T4 or recombinant any other distractor. So it is the T3 which will be acting quickly. Next we have got estimation of thyroid auto antibodies. Nowadays we come across a lot of autoimmune disorders or thyroiditis. So this forms a very mainstream investigation for diagnosing the autoimmune disorders. So serum levels of antibodies against thyroid peroxidase, which are called as TPO, which is previously referred to as thyroid microsomal antigen. So and thyroglobulin. So antibodies against TPO and thyroglobulin are most useful in determining the cause of thyroid dysfunction and the swellings. Autoimmune thyroiditis may be associated with thyroid toxicity, failure or euthyroid goiter. So whenever patients present to you with just simple goiter, so you may choose to investigate for thyroid antibodies. These are called thyroid autoantibodies. When you see patients with goiter, approximately out of them 80% of the patients with Hashimoto's thyroiditis have elevated thyroid antibody levels. But levels may be also increased in patients with Graves' disease, multinodular goiter and occasionally with thyroid neoplasms. So you have got elevated levels of thyroid antibody levels in Hashimoto's thyroiditis followed by Graves' disease, multinodular goiter and occasionally with thyroid neoplasm. So you may be asked a question, the levels of thyroid antibody levels, that is antibodies against thyroid peroxidase, they are elevated in which of the following diseases? Except levels above 25 units per ml for thyroid peroxidase antibodies and titers of greater than 1:100 for antithyroglobulin are considered significant. So when you got TPO autoantibodies more than 25, then it is a significant titer, and this is to be diagnosed as autoimmune thyroiditis. The presence of antithyroglobulin antibody interferes with serum assay of thyroglobulin with implications for the follow-up of thyroid cancers. The presence of antithyroglobulin antibody is very important because many of the thyroid cancers can be followed up after its estimation. Next we have got serum thyroglobulin. Thyroglobulin is not normally released into circulating hormone. So serum thyroglobulin estimation, it will increase dramatically in destructive processes of thyroid gland such as thyroiditis or overactive states such as Graves' disease and toxic multinodular goiter. So serum thyroglobulin estimation will give a status of the functioning or remaining of the thyroid parenchyma. The most important use for serum thyroglobulin level is monitoring patients with differentiated thyroid cancer for recurrence, particularly after total thyroidectomy and radioactive iodine ablation. So whenever you have patients whose near total or thyroidectomy done and he is followed with radioiodine, or total thyroidectomy has been done, if you measure thyroglobulin concentration and if you find it is rising, so you should suspect that either recurrence has occurred or the recurrence of the disease is again coming. So you should monitor these patients with serum thyroglobulin levels whenever you have done total thyroidectomy for malignancy. Next we have got thyroid imaging. We have got radionuclide imaging, which is the mainstay of diagnosing of the various thyroid disorders. So both iodine 123 and iodine 131 are used to image thyroid gland. Friends, here I want to make clear very much confusion, that is iodine 123 and iodine 131. So many of the students do confuse between these two isotopes. So the former emits, that is iodine 123, emits low dose of radiation and it has got a half-life of 12 to 14 hours. So it is used to image lingual thyroid or goiters. So iodine 123 has got a lesser intensity of its radiation. But in contrast, iodine 131 use leads to higher dose radiation exposure and has got half-life of 8 to 10 days. So iodine 134 is used to screen and to treat patients with differentiated thyroid cancers for metastatic disease. So after you are done with thyroidectomy, to burn out the cells which are remaining in the thyroid bed or anywhere in the body, you have to give iodine 131, it will act as a radiating dose. Areas that trap less radioactivity than surrounding gland are termed as clolled. So whenever you do thyroid scan for any hyperthyroidism, so whenever you have got raised T3, T4, you may do thyroid scan. So it will have areas which are termed as cold, whereas areas which demonstrate increased activity, they are termed as hot. The euthyroid state or the normal uptake of the gland is named as warm. The risk of malignancy is higher in cold lesions, that is 15 to 20%, than in hot or warm lesions. So it has got less than 5%. So whenever you got cold lesion, the risk of malignancy is 15 to 20%. And in hot or warm lesions, the risk of malignancy is less than 5%. So this is very important from diagnosing what is the type of lesion point of view. Next we have got technetium 99M, per-technet scan. So technetium 99, that is called as per-technet, it is taken up by thyroid gland and it is also used for thyroid evaluation. It has got the advantage of having shorter half-life and it will minimize the radiation exposure. It is particularly sensitive for nodal metastasis. So if you are asked question, if you are to do a nodal scan for assessing the status of nodal metastasis, which of the following scans is important? So it is not iodine 123, not iodine 131, it is per-technet scan which is more important. Nowadays 18F fluorodeoxyglucose, that is positron emission topography, has been used to screen for metastasis in patients with thyroid cancer in whom other imaging studies are negative. So if you want to find out occult metastasis or if you have got rising trends in thyroglobulin after total thyroidectomy, then you can use 18F fluorodeoxyglucose, that is PET scan, for evaluation. Next we have got ultrasound. Ultrasound is excellent, non-invasive and portable imaging method for studying the thyroid gland, and it has got added advantage of no radiation exposure. So it can be performed as many times as possible. So it is helpful in evaluation of thyroid nodules, distinguishing from solid and cystic lesions, and providing information about size and multicentricity. Many times, if you have got a solid component in a cystic lesion, you can get guided FNAC from the solid component of the cystic lesion. So this is very valuable tool to have real-time imaging. CT and MRI scan can also be used to assess nodal status and malignancy spread. But mind well, so when you want to do CT scan, you have to avoid contrasts because all the contrasts are iodine containing and they will interfere in radioiodine uptake levels if you want to ablate the remaining residual malignant thyroid tissue. So you may be asked question on this point that which scans are preferred, you do give contrast or if you do non-contrast scans after evaluation for malignant thyroid lesions. Friends, having seen various investigations, now we'll see benign thyroid disorders. So benign thyroid disorders can be of hyperthyroidism or they can be giving rise to hypothyroidism. So it is important to distinguish disorders such as grave disease and toxic multinodular goiters that result from increased production of thyroid hormone from those disorders that lead to release store of thyroid hormone or injury to the thyroid gland, which is named as thyroiditis. So you should be differentiating between hyperthyroidism that may be arising from increased production of thyroid hormone or increased release of thyroid hormone which is already stored. So you have to differentiate between these two disorders. Now we'll see what are different disorders which will either form more thyroxine or release the more form thyroxine. So the former disorders that lead to an increase in radioactive iodine uptake, whereas the latter group is characterized by low radioactive iodine uptake. So disorders in which you have got increased hormone synthesis with increased radioiodine uptake, these are grave disease, which is also called as diffuse toxic goiter. Then we have got toxic multinodular goiter, plumber's disease, which is also called as toxic adenoma. Then drug induced may be seen after amiodarone or after giving iodine. So if you have got increased hormone synthesis after iodine therapy, it is also called as George-Basidos disease. So George-Basidos disease is seen after which of the following conditions. So you may be given various options. So it is mainly after iodine supplementation you get increased hormone synthesis called as George-Basidos disease. Next, we have seen increased hormone synthesis in thyroid cancer, struma ovarii, hydatiform mole, or TSH secreting pituitary adenoma. So whenever you got more of TSH secreted by pituitary adenoma, it will increase the synthesis of thyroxine. Next, we will see what are the disorders which are increase in serum thyroxine concentration more from release of preform hormone, so which have decreased radioactive iodine uptake. So whatever thyroid hormone which is already being formed, it is released in circulation. So it is seen mainly in following conditions such as thyroiditis, whenever you have got inflammation of thyroid gland which will lead to the increased secretion of thyroid hormone in the circulation, seen in acute phase of Hashimoto's thyroiditis, subacute thyroiditis. You have got also condition of factitious, that is iatrogenic thyrotoxicosis. Next we have got the hamburger thyrotoxicosis, in which you see increased release of preform hormone by thyroid gland. Friends, now we'll see Graves' disease. So it is originally described by a Welsh physician called as Caleb Perry. So you may be asked question, or Graves' disease is described first by, you may write as Graves, but it is not Graves, it is Caleb Perry. He has described it first around 10 years before Graves has described it. So Graves' disease is by far the most common cause of hyperthyroidism in North America, amounting for 60 to 80% of cases. So which of the following is the most common cause of hyperthyroidism? It is the Graves' disease. It is an autoimmune disease of unknown cause. It has got a strong familial predisposition with female preponderance of 5:1 and peak incidences between ages of 40 and 60 years. Graves' disease has got following characters by thyrotoxicosis. It will cause diffuse goiters, then extrathyroidal conditions including ophthalmopathy, dermopathy, that is pretibial myxedema, thyroid acropathy, and gynecomastia. What is the etiopathogenesis? The exact etiology is not known. Conditions such as postpartum state, iodine excess, lithium therapy, and bacterial or viral infections have been suggested as possible triggers. So if you are given what are the possible etiological factors, you should remember these 3-4 main factors. Next, we have got the thyroid stimulating antibodies that stimulate the thyroid receptors as well as TSH binding inhibiting immunoglobulins or antibodies. These are called as TBIAs. So thyroid stimulating autoantibodies, these are main factors. So thyroid stimulating antibodies stimulate the thyrocytes to grow and synthesize excess of the thyroid hormone. So Graves' disease is also associated with other autoimmune conditions as type 1 diabetes mellitus, Addison's disease, pernicious anemia, and myasthenia gravis. So following conditions should also be remembered because they may be associated with Graves' disease. Symptoms most common presented with, so patients will have intolerance to heat, increased sweating and thirst, and weight loss despite adequate calorie intake. The symptoms of increased adrenergic stimulation, they include palpitation, nervousness, fatigue, emotional lability, hyperkinesis, and tremors. So along with all these symptoms, we can have gastrointestinal symptoms like increased bowel movement that leading to diarrhea. Female patients often develop amenorrhea, decreased fertility, and increased incidences of miscarriages. Children experience rapid growth with early bone maturation, whereas older patients with cardiovascular complications may have got atrial fibrillation and they may have caused congestive cardiac failure. Along with this systemic component of thyrotoxicosis, Graves' patients also have got evident ophthalmopathy. So the eye symptoms include lid lag, that is von Graff's sign, and spasm of the upper eyelid revealing sclera above corneoscleral limbus, that is called as Darling test sign. So these signs may be asked for you in exams. They have a prominent stare as a consequence of catecholamine excess. So all the patients who have got ophthalmopathy have got autoantibodies or antigens against the retroorbital tissue or the muscles, leading to the proptosis. So orbital fibroblasts and muscles are thought to share a common antigen with thyrocytes, the TSH receptor. So ophthalmopathy results from the inflammation caused by cytokines released from sensitized killer T lymphocytes and cytotoxic antibodies. Next, we have the term of thyroid acropathy. So it is the bony involvement that leads to the subperiosteal bone formation and swelling in the metacarpus. So you may be asked question, thyroid acropathy is best described by, then they will give you 4 options in which this sentence will be there. So you should choose this sentence properly because you may confuse this acropathy with any of the other diseases because acropathy doesn't directly strike in the mind which of the structures which is involving. Next, we have got various diagnostic tests. The suppressed TSH with or without an elevated free T4 or T3 level. This is the main diagnostic test. But if eye signs are present, the other tests are generally not needed. In absence of eye findings, an iodine 123 uptake and scan should be performed. So these 3 sentences describing tests, these are very important. An elevated uptake with diffusely enlarged gland confirms the diagnosis of Graves' disease and will help to differentiate it from other causes of hyperthyroidism. If free T4 levels are normal, free T3 levels should be determined as they are often elevated in early Graves or Plummer's disease, that is called a 3T toxicosis. So these same T3 levels, free T3 levels we have seen earlier that were discussed they are useful to detect early hyperthyroidism. Anti-TG or antithyroid peroxidase antibodies are elevated in up to 75% of the patients, but they are not specific. Elevated thyroid stimulating hormone receptor or TSAP are diagnostic of Graves' disease and are increased approximately in 90% of the patient. So this is very important statement. So if you are asked question, which of the following tests will give you 100% diagnosis of thyroid Graves' disease, then these are the thyroid elevated. So these are the elevated thyroid stimulating hormone receptor. These are called as TSAPs, thyroid stimulating hormone receptor antibodies. So next we have got the MRI scan, which will be helpful in imaging in patients of thyroid ophthalmopathy. What are the main treatment options for the Graves' disease? We have got 3 treatment modalities for Graves' disease. These are antithyroid drugs. We have got thyroid ablation with radioactive iodine, that is iodine 131, and surgery. Next we will see all these 3 factors one by one. The choice of the treatment depends on the age of the patient, severity of the disease, size of the gland, coexisting pathology, associated ophthalmopathy, patient's preferences and desire for pregnancy. So these all factors are very important in deciding the treatment modality, because results of each treatment or each modality of the treatment will differ. Next we have got antithyroid drugs. So medications commonly used are propylthiouracil, which is given 100 to 300 mg 3 times a day, and methimazole, which is given 10 to 30 mg 3 times a day. So methimazole can also be given once a day because it has got longer half-life. So friends, many of the times questions are asked on these antithyroid drugs. So go through these statements carefully. Both drugs reduce thyroid hormone production by inhibiting organic binding of iodine and coupling of iodothyroxine, which is mediated by thyroid peroxidase. In addition, propylthiouracil will also inhibit peripheral conversion of T4 to T3, making it useful for treatment of thyroid storm. So on this single line, you can be asked which of the following is drug of choice for thyroid storm, or which of the following drugs will prevent peripheral conversion of T4 to T3. So this is very important from MCQ point of view. But both drugs, they cross placenta, inhibiting fetal thyroid function and are excreted in breast milk. Although propylthiouracil has a lower risk of transplacental transfer. So which of the following drugs has got low risk for transplacental transfer? It is propylthiouracil. Along with all these side effects, methimazole is also associated with congenital aplasia. Therefore, propylthiouracil is more preferred in pregnant and breastfeeding women. So you should carefully choose the answer as propylthiouracil, which is preferred in pregnancy and breastfeeding women. Next, we have got the radioiodine therapy. The major advantages of this form of treatment are avoidance of surgical procedure and its concomitant risk, with reduced overall treatment cost and ease of treatment. So when patient doesn't want risk of recurrent laryngeal nerve palsy, they prefer to go for radioiodine therapy. Antithyroid drugs are given until the patient is euthyroid, and they are discontinued after that to maximize drug uptake. So antithyroid drugs are given to make patient euthyroid, and they are discontinued because after you discontinue antithyroid drugs, then the gland becomes thyroid iodine avid. So it will want to have more of iodine in it. So it will get maximum amount of the iodine, that is radioiodine, given to the patient. The iodine 131 dose is calculated after preliminary scan and usually consists of 8 to 12 millicurie administered orally. Mind well, the patient, this is very important because radioiodine is not given intravenously but it is given orally. Radioiodine is associated with progressive development of hypothyroidism of 70% over 11 years that will require lifelong thyroxine hormone supplementation. What are the indications? Older patients with small or moderate size goiters, in patients who have relapsed after medical or surgical therapy, and in patients whom antithyroid drugs or surgery are contraindicated are indications for radioiodine. What are the absolute contraindications? Patients who are or women who are pregnant or breastfeeding. Relative contraindications are in young patients, especially children and adolescents, patients with thyroid nodules, and patients with ophthalmopathy. Next, we have got the last option of the treatment, which is surgical treatment. What are the indications? Indications are where the radioiodine is contraindicated. Next, when we have got confirmed cancer or suspicious thyroid nodules, you should be better removing them out rather than to treat with radioiodine. Young patients who may be desirous of getting rid of tissue, they may be offered surgical treatment. Patients who are pregnant or who desire to conceive soon after treatment should be offered surgical treatment. Patients who have an allergy to antithyroid medications, they may be given surgical option. Large goiters causing compressive symptoms should be offered surgical treatment as initial modality. So for treatment of choice for large goiters causing compressive treatment, you may be given option of 3. So it is the surgical treatment is the treatment of choice for large goiters. Patients who are reluctant to undergo radioiodine therapy should be offered surgical treatment. Friends, now a few words for Lugol's iodine. So it is Lugol's iodine solution or supersaturated potassium iodide solution should be administered preoperatively. The dose is 3 drops twice daily beginning 10 days preoperatively to reduce the vascularity of the gland and decrease the risk of precipitating thyroid storm. The major action of iodine in this situation is to inhibit release from thyroid hormone. Along with the other aspects of treatment, it is the surgical treatment only which will reduce the ophthalmopathy. So ophthalmopathy has been demonstrated to stabilize or improve in most patients after total thyroidectomy, presumably from removal of antigenic stimulus. So patients who have got more of ophthalmopathy, they should be offered surgical treatment. Friends, today we saw what are the various thyroid disorders, various investigations, and we saw various benign disorders, amongst which Graves' disease is the very much important disease to see. Thank you.